Assalamu alaikum. This is another lecture of neuroanatomy in which we will discuss cranial nerves. The topic for today is the vagus nerve. Vagus is the 10th cranial nerve. By the end of this lecture, you will be able to know about the nuclei of vagus nerve, its course, branches, its evaluation, and finally the lesions. Why this nerve is known as vagus nerve? Vagus nerve has been derived from vagabond. This nerve uh, arises from the brainstem. It gives branches in the brain. Then it gives branches in the head and neck region. It travels down through the thorax into the abdomen as it travels almost throughout the body and the viscera. So this is known as the vagus nerve. Now we come to the nuclei of this nerve. This nerve has got four nuclei. One is the nucleus ambiguous, that is present in the medulla. Other one is the dorsal vagus nuclei that are also present in the medulla. Then the nucleus tractus solitarius that carries general and special visceral efferents, that is also present in the medulla but in the lower part of it. Then is the sensory nucleus of trigeminal nerve that carries general somatic efferents. It is present in the pons and up to the level of C2. Vagus nerve leaves the anterolateral surface of the upper part of the medulla oblongata as a uh, series of fruitlets. Here you can see in this picture. Here you can see this is the 10th cranial nerve, and see how many rootlets are there. The rootlets in the groove between the olive and the inferior cerebellar peduncle. The nerve passes laterally through the jugular foramen. At the level of the jugular foramen, it has got two bulbs. Here in this picture, you can see where there is marking of 1 and 2, and the pointer is also moving there. You can appreciate the presence of uh, two sensory ganglia of the vagus nerve. These are the superior and inferior vagal ganglion. The superior one is rounded, situated on the nerve within the jugular foramen, and the inferior one is cylindrical, lies on the nerve just below the foramen. Below the inferior ganglion, the cranial root of accessory nerve joins the vagus nerve and is distributed mainly to pharyngeal and recurrent laryngeal branches. The fibers of the accessory and the vagus nerve, they both travel uh, in pharyngeal and recurrent laryngeal branches. In the head and neck region, the first branch that it gives within the jugular foramen and its fossa is the meningeal branch that supplies sensory fibers to the dura mater of posterior cranial fossa, and also gives auricular branch that supplies the ear. Here you can see after coming out of the jugular foramen, this nerve descend in the neck, descend in the carotid sheath, Um and it also gives some branches. The first branch that arises, this is not the first, this is the third branch that arises from uh, the the vagus nerve, is the superior laryngeal nerve. The superior laryngeal nerve is given at the level of greater cornu of the hyoid bone. It then, when it reaches at the level of the thyrohyoid membrane, it divides into two branches, the internal laryngeal and the external laryngeal nerve. The internal laryngeal nerve is sensory to uh, the cavity of the larynx up till the level of the vocal folds, while external laryngeal nerve, it curves downwards and supply motor fibers to the cricothyroid muscle. Then the next branch that arises from the vagus nerve is the recurrent laryngeal nerve. The recurrent laryngeal nerve, it comes downward and it loops around the subclavian artery, and then again it ascends in the tracheoesophageal groove. It supplies all the muscles of the larynx except cricothyroid, and it also gives sensory supply uh, below the to the cavity of the larynx below the level of the vocal folds. Then this nerve descend in the neck, in the carotid sheath posteriorly, and enter the thorax anterior to the subclavian artery. In the neck, the right and left vagi, they both follow different courses. The right vagus nerve, it enters the thorax and passes posterior to the root of the right lung, contributing to the pulmonary plexus. It then passes onto the superior surface of the esophagus and contribute in the formation of the esophageal plexus. Then it enters the abdomen through the esophageal opening of the diaphragm. The posterior vagal trunk is distributed, it is also known as the right vagus, is distributed to the posterior surface of the stomach and by large celiac branch to the duodenum, liver, kidneys, small and large intestines, as far as the distal third of the transverse colon. This wide distribution is uh, accomplished through the celiac and superior mesenteric and renal plexus, while the left vagus enters the thorax and crosses the left side of the aortic arch, and descend behind the root of the left lung, contributing in the formation of the pulmonary plexus. Then it descends on the anterior surface of the esophagus and form esophageal plexus. It enters the abdomen through esophageal opening of the diaphragm, and the anterior vagal trunk, that is also known as the left vagus, divides into several branches which are distributed to the head of the pancreas, stomach, liver, and upper part of the duodenum. By this, we come to the end of the vagus nerve. Now we come to its evaluation. It is evaluated by the uh, gag reflex, cough reflex, and vomiting reflex. The gag reflex involves glossopharyngeal nerve and its nucleus ambiguous efferent to the pharyngeal muscles. Then cuff reflex efferent uh, comes from nucleus tractus solitarius, and they are connected to the respiratory centers. Also from the nucleus tractus solitarius, nucleus ambiguous, efferent fibers of the 10th nerve, laryngeal and pharyngeal muscles. Then vomiting reflex, uh, it arises from efferents of the 10th nerve, which is the vagus nerve, by its nucleus troctus solitarius, nucleus ambiguous, which carry efferent from the nucleus ambiguous, which carry efferents and closes the glottis. Then the efferent fibers from the 10th nerve, they are carried uh, by nucleus tractus solitarius, its reticulospinal tract, then contraction of the diaphragm and the abdominal muscle that aid in the vomiting reflex. Now we come to the autonomic evaluation of the vagus nerve. Ipsilateral decreased carotid sinus reflex may be seen because vagal outflow is necessary. The bilateral vagal dysfunction is associated with tachycardia and another signs of sympathetic overactivity. Because these are the vagus supplies the heart through sympathetic plexus as well. Now we come to the lesions of the vagus nerve. The first is the hoarseness of voice, and second one is the difficulty in swallowing. The hoarseness of voice can come by unilateral vagal injury, lead to failure of the palate elevation, uvula deviation away from the affected side, and unilateral vocal cord paralysis that leads to hoarseness of voice. Then are some lesions which include recurrent laryngeal nerve paralysis that can also lead to hoarseness of voice and difficulty in swallowing, etc. Recurrent laryngeal nerve damage are most commonly due to malignant diseases, and because of the longer course of the recurrent laryngeal nerve, lesions of the left nerve are much more frequent than those of the right. In case of complete unilateral paralysis of the vocal folds, the cord take up an intermediate position between full abduction and adduction. Here you can see the voice is hoarse and the patient cannot cough in a usual explosive manner. In an incomplete lesion, the cord take up an adducted position, that is, the power of the abduction seem to be lost first. There is no universal acceptability to this explanation, however. Then the high lesions of the vagus nerve, which affect the pharyngeal and superior laryngeal branches, and the recurrent laryngeal nerve, causes difficulty in swallowing and also vocal fold defects. The bilateral paralysis that causes loss of phonation and difficulty in somewhat difficulty in breathing as well. By this we come to the end of the vagus nerve. Thank you for your attention. Allah Hafiz.